So welcome to today's webinar, a look at genetic testing with presentations from experts on both sides of the Atlantic. For those in the US, this is not the time of day we usually do our webinars, but so many people all over the world stay up late or get up early to hear from our experts. So today we changed it up a bit, and we'll be doing this more in the coming year to give more people around the world access to leaders in the fields of Marfan, loeys-dietz, and beds. So a few housekeeping details before we get going. If you have any questions, put them in the Q&A box, not in the chat box. Try to keep them short and general rather about your personal situation, because we want to answer as many questions as we can from people. And personal details, it's hard to do that in this kind of format, but we will be leaving time at the end for your questions. And if your questions are not answered, please submit them to our help center, and Jan, our nurse, will get you the answers, and we will post that link later on during this webinar. So now I would just like to introduce our President and CEO, Michael Weimer, who wanted to say a few words.
Thank you, Eileen. Hi, everybody. So nice to be part of this. I bring you greetings from Tim Eagle, Dr. Eagle, who is the chair of the GenTAC Alliance, as well as the Marfan Foundation. And we're really pleased to have GenTAC as part of our organization. Amazing group of physicians and scientists that really do provide the best information available on almost any topic you can imagine in either Marfan or related conditions. So I love this topic. I think it's probably one of the more frequent items that comes up in discussions with anyone, whether you're in the US or Europe or other places around the world, is not only the need for genetic testing, but the differences. And so I'm as anxious to see this these presentations as you are. Also, just want to remind you, we will be in Chicago this year for our conference. If you've been to a conference before, it's a wonderful opportunity to spend time with members of the community, but also some of the most significant and important physicians and medical professionals anywhere in the world. So July 13 to 16 in Chicago. We still have opportunities for people to register for the health fair, at least for the next few days. So if you're thinking about coming or have already registered and would like to participate in the health fair, please fill out that application, and we'll be glad to take a look. Also, scholarships continue to be open as well. So if you need some assistance in traveling to Chicago from wherever you may be, we would be glad to consider that as well. So with that brief introduction, I'm going to sit back and enjoy this extraordinary presentation. Thank you.
Thank you. Thank you, Michael. So I will just briefly introduce our two presenters today. Probably not as brief as you think. They both have a lot of credentials here, so we're going to hit some highlights. First, Dr. Laura Muino Mosquera is a pediatric cardiologist and cardiogeneticist at Ghent University Hospital in Belgium. She received her medical degree at the University of Navarra in Spain and her doctorate at Ghent University. She then did specialized training in pediatrics and did research in Marfan in Brussels, the UK, and in Ghent. And she has a special interest in clinical and genetic aspects of heritable thoracic aortic disease and in cardiomyopathies, and has published several papers on these topics. What I love about Laura is that she speaks Dutch, English, French, and Spanish. So she's my right hand in a lot of ways. She's presented in our Spanish Summit, both times we did it, our first 2 years. This year, she served on the organizing committee, and she continues to volunteer her time to help the foundation develop its Spanish programming. Soon to be Dutch, French as well, Laura, so heads up on that. Jessica Kushner has been a practicing genetic counselor in the US for close to 25 years. She earned her undergraduate degree as well as her master's in medical genetics, genetic counseling from the University of Wisconsin in Madison, go Badgers. She has been a genetic counselor at Oregon Health and Science University in Portland, Oregon since 2001, specializing in cardiovascular, connective tissue disorder, and pediatric genetics. From 2007 to 2012, she was the OHSU Site Clinical Research Coordinator for GenTAC, a national genetic aortopathy registry, working to identify aortopathy genes and collection of patient data for use in clinical care. For the last 10 years, she has been part of the team of clinical geneticists and genetic counselors providing diagnostic, evaluation, and care at the OHSU and Dornbecker Children's Hospital in Portland. I'm privileged to work with both of our speakers on GenTAC, the GenTAC Alliance's patients, families, and clinicians education working group. So I've gotten to know both of them over time and looking forward to hearing their presentations. So without further ado, I'm going to pass it over to Laura to start us off.
Thank you, Eileen, for this fantastic introduction. I think I've never been introduced in such a beautiful way before. I'm going to try to share my screen so that we can get started. So if that's okay, you should be seeing my screen. I don't know if you see the presenter view or the...
Yes, we see presenter view.
Okay, just let me check this. Just give me a second. I'm going to put it out then. So this should be better.
Perfect.
Yeah, great. So as I was saying, well, Eileen, thank you so much for your very kind introduction. And thank you for having invited me today to give this presentation. I really love to participate in this type of initiatives. What are we going to see today in this webinar? I will try to talk to you about some concepts of genes and inheritance, because I think that's going to be important to understand some of the things I will be discussing later on the genetics of hereditary thoracic aortic disease. And I think that it might help you to understand some of the things that your doctors explained you in the past. And it's going to be also important to understand how that the diseases can be transmitted within one family. So I will start by the very basic, sorry, I'm having some trouble with my slides. Well, I will start with showing you how DNA is packed in our cells. So the DNA, our genetic material, is formed. The biggest unit are the chromosomes. There we have 23 pairs of chromosomes. Within those chromosomes, we have the genes, and we have more than 30,000 genes in our body. And each gene has two parts. Ones are the exons, and the other ones are the introns. Before, the exons were thought to be the coding DNA, and the introns were thought to be the non-coding DNA, the sort of junk DNA. But actually, the more that we know about our genetic material, the more that we know that actually the introns play a very important role in our genetic material. If we go further more into detail, we see that our genetic material is formed by a letter code, and there are actually 4 letters, A, C, G, and T, which are combined with each other and which form basically our genetic codes. And those letters are called the nucleotides, and we have 3.2 billion nucleotides in our body. If you would compare this, what I just explained you, to a library, you could say that the chromosomes altogether, there are the library, which is formed by different books, each of those books being a chromosome. If you would open a book, then you could have a chapter which correlates with the gene. And with that book chapter, you have the written part, they have the story, which are the exons, and you have the figures, which you could compare to the introns. The figures, they can have very important information. They can help a lot to understand the story. But if you would see those figures just isolated, probably they will not tell you too much of a story. So the combinations of the figures and the text are very important, just like the combinations of the introns and the exons are very important. And then if you look deeper into the chapter, then you will have the letters who form your story, and those letters, the content in itself, those are the nucleotides. I'm sure that you have all heard about the Human Genome Project. That was a project which was carried out at the latest 90s, and in the beginning of the 2000s, about 90% of the genome of the human DNA was deciphered. This was, of course, the main focus of the Human Genome Project. Why do I explain this? Is because this has been the basis of what we now understand as the sort of standard human DNA, which is the human genetic blueprint. But this Human Genome Project was, at least originally, based on 20 volunteers. And why do I say this? Is that because you can understand that the genetic code from 20 volunteers cannot represent all the possible variations that can be present in the human genetic code. Why is that? Because each of us has a very unique and very specific genetic code. So that means that whenever that we do genetic testing by each of us, and when we compare the results of our genetic testing to that standard DNA which was established years ago, then we can find differences in the letter code. For example, here in the image above, you can see a T instead of a C. And that's what we call the genetic variation. And when we do genetic testing, and we find a lot of genetic variation in each person. The challenge is, of course, well, that genetic variation, is that just normal genetic variation, which explains why each of us is different, why each of us has a unique genetic material, or is that genetic variation causing a disease? And of course, if we have that genetic variations in genes which are responsible for the color of your eyes, for example, then usually we would think that that's normal genetic variation, which explains why some people have blue eyes, while other people have green eyes. But if those variants are found in genes who are, for example, responsible for the way that the heart works, then we have a little bit more of difficulty in knowing how to interpret those variations. And we have a relatively complex way of knowing how to classify those variations. We have a system in which we can say, okay, there are some variants which are going to be normal genomic variation. Those variants we call benign or likely benign. And there are going to be other variants in which, based on certain things, we think that might cause a disease. And those variants we called likely pathogenic or pathogenic variants. And between these two groups, you have the variants of unknown significance, and that actually means that we don't know so well what those variants really mean. But how can genetic tests be performed? Well, in theory, we can extract DNA from any tissue in our body, but usually we would isolate DNA either from blood or from saliva. And there are different techniques that we can apply to do genetic testing. The oldest one, the one which was developed at the beginning, was the targeted gene sequencing. That means that we're going to look at one gene. So for example, when we have a patient which we find that has very, very specific clinical features of, for example, Marfan syndrome, we can decide to just look at the gene which causes Marfan syndrome, namely the fibrillin-1 gene. This is, if you would compare it to going fishing, this would mean that you would need to fish by fish every time that you need to do genetic testing. A second way of doing genetic testing, which is the most common, which we applied to patients with thoracic aortic disease, is when we concentrate of a group of genes which can all cause, for example, thoracic aortic diseases. And this is what we call the panel sequencing. And the testing which has been developed the latest is the whole exome or whole genome sequencing. In the whole exome sequencing, we looked only at the exons, while in the whole genome sequencing, we look at both at the exons and at the introns of our genetic material. Of course, with that, with this last technique, we get a lot of information, but it is very, very challenging to interpret all the information that we have, because we need to make a distinction in between those things which are relevant for our patients in opposition to those things which are actually just a bit junk information, if you could call it like that. And whole exome and genome sequencing usually is more used at this point for research, although slowly it's getting more and more applicable in the clinical practice. Why is genetic diagnosis important? I think it's important for many things. I just stated 4 here. One is because it helps to establish the diagnosis. It helps to determine the best possible treatment for our patients. It helps to identify other family members which might be at risk of having the disease. And it helps prevent transmission of the disease to the next generation, at least in those countries where prenatal diagnosis is legal. And we're going to apply all that we have seen now to the hereditary thoracic aortic diseases. What are hereditary thoracic aortic diseases? Those are diseases which affect the aorta. And the aorta is the main vessel of our body, which brings blood from our hearts all the way to all organs. And there are 2 ways of having a disease of the aorta. One is if you have an aortic enlargement, which you call an aneurysm, but there are people who present from the first time with an aortic dissection. An aortic dissection that is a tear in the layers of the aorta, which cause actually a separation between the different layers of the aorta. And as you can see here in this figure here, there is an accumulation of blood between the layers of the aorta. An aortic dissection is a life-threatening condition, especially if it affects the proximal, so the very first part of the aorta, that part which directly goes out from the heart. Within the hereditary thoracic aortic diseases, we can distinguish 2 big groups. One is the syndromic group, and we call syndromic when patients have not only an aortic problem, but when they also present some additional features. And we talk about non-syndromics when there is only an aortic problem, and if you would not perform an echo or any imaging to visualize the aorta, you would have a lot of difficulty in knowing that that person has a aortic disease. I will come into this back later on. I would just want to mention that all these diseases have one thing in common, and that is that they have an autosomal dominant way of transmission. What does that mean? Is that these are diseases which usually runs in families. Some cases are de novo, so that means that there is one member of the family in which for the first time the disease has started, and it can be transmitted from parents to children. When we talk about this, autosomal dominant inheritance means that there is a 50% chance of transmission to the next generation, and that it affects women and men equally. I have taken this picture from internet. This is, I think, one of the most common ways that pedigree with an autosomal dominant inheritance is depicted. So here you can see a father which is affected, a mother which is unaffected, with 4 children, and half of them, so this daughter here and this son here, are affected, while other 2 are not affected. This is a representation of that 50% chance of transmission. What I personally don't like about this picture is that it gives a wrong idea on what 50% of transmission is. Why? Is because the transmission is 50% for each child. So if a couple have 4 children, it's not that 2 will have the disease and 2 will not have the disease. No, each of the children has 50% chance of having the disease. So you could end up theoretically with these 2 other pedigrees in which, for example, you have 3 children who are unaffected and 1 child which is affected, or the other way around, you could have 3 children who are affected and 1 child which is not affected, because each child, again, has a 50% chance of having inherited the disease from an affected parent. If we go back to the non-syndromic ways of thoracic aortic diseases, those are the ones who only have an aortic problems. You can see that there are many genes which are involved. This is just a figure that I took from a publication from our colleagues from France, which was published in 2019. And here you can see the most frequent genes which are involved in non-syndromic thoracic aortic disease. And those of you who have listened to these talks in previous times will notice that some of the genes which are here are actually known genes of the syndromic forms of thoracic aortic diseases. Fibrillin 1, for example, is the gene which causes Marfan syndrome. TGF-beta receptor 1, TGF-beta receptor 2, TGF-beta 2, and SMAD3 are genes actually who are responsible for Loeys-dietz syndrome. What I want to say with this is that the more we know about the diseases, the more we see that maybe the old classification of syndromic versus no syndromic is not so much up to date anymore, but that probably there is a sort of a spectrum in which you will have people who have very severe non-cardiac manifestations and other people which will have only the cardiac manifestations of the disease. When we looked at the syndromic forms of thoracic aortic disease, the 3 most common are Marfan syndrome, Loeys-dietz syndrome, and vascular Ehlers-Danlos syndrome. And each of these diseases have some distinctive features. For example, patients with Marfan syndrome, beside the aortic dilatation, they usually have, or they can have, ocular problems in which the lens of the eye is dislocated. Patients with Loeys-dietz syndrome, they might have specific facial features in which the eyes might be a bit more separated from each other. They have this the uvula, which is bifid, and patients with vascular EDS might have a very thin skin, very transparent skin, may have also some specific facial features. But at the same time, each of these syndromes also have overlapping features in which, and these features can be present in all of them. For example, long fingers, although they are typical of Marfan syndrome, they can be present in patients with Loeys-dietz syndrome and vascular EDS syndrome. Scoliosis, chest anomalies, pneumothorax, those are all features which are overlapping in different syndromes. That means that when we see patients in our clinics, sometimes we will distinguish them very clearly and we will know this patient has Marfan syndrome or this patient has Loeys-dietz syndrome, but because of the overlapping features, sometimes it is very difficult just from a clinical perspective to distinguish the underlying problem that a patient has. But it is very important, as I mentioned earlier, each of these diseases is associated with a mutation, with a pathogenic variant in a different gene. And we know from research that the risk, for example, of having an aortic problem, either aortic surgery or aortic dissection, will depend on the risk, the gene, which is involved. So, for example, if we looked at the genes involved in the TGF-beta pathway, the genes which can cause Loeys-dietz syndrome, then we see that those patients carrying variants in the TGF-beta receptor 1 have a much higher risk of having aortic problems than those patients having a pathogenic variant in the SMAD3. And this information that we have gained through research has recently been taken into the new recommendations of the American Heart Association on when patients with this syndrome should be operated. So as you can see, for example, a patient with a mutation in fibrillin 1 should be operated when the aortic diameter is 50 millimeters or for 45 millimeters in some cases where the risk is increased. On the other hand, patients with loeys-dietz syndrome should be operated when the diameter is lower, when the diameter is 45 millimeters or even 40 millimeters in some cases. Vascular Ehlers-Danlos syndrome is a very different illness than Marfan syndrome and loeys-dietz syndrome. Patients with vascular ADS have a much higher risk of having aortic arterial dissection, so outside of the aorta. And here in Europe, we normally treat them with celiprolol. In the United States, celiprolol is not approved, so they usually are treated by other types of beta blocker. And this is different to patients with Marfan syndrome and loeys-dietz syndrome, which are also treated with beta blockers, usually atenolol, but also sometimes receive losartan, for example, something which for vascular EDS has not been really shown to have any effect. At the same time, the surgical thresholds for vascular Ehlers-Danlos syndrome and the recommendations are also different than for those patients with Marfan syndrome or loeys-dietz syndrome. So knowing the underlying genetic condition is really important for the way that we treat our patients. So what have we learned, I think, is that we have looked at some concepts, a basic concept of genetics. I think I showed you that genetic testing is not difficult to perform. You only need a blood test or a saliva. Thoracic aortic diseases are transmitted in an autosomal dominant way. Knowing the underlying gene is very important for an appropriate treatment, and knowing the underlying gene can help, of course, other family members through segregation of the certain variants. And with this, I would like to thank you for listening. And I think after Jessica's presentation, I will be very glad to take any questions.
Perfect. Thank you so much. And Jessica, you can now share.
Let's see.
I think, Laura, you need to stop sharing.
Yeah, I'm going to.
It says I can't share my video, I think maybe until you turn something on.
I'm having. Yeah, I see. Sorry.
There you go.
Sorry, I couldn't find the button to stop sharing.
Yeah, it says you can't start your video because the host has stopped it.
Okay, let me look here. One advanced sharing. One panelist at a time. Okay, it's you, host and panelist. Okay, go ahead, see if you can do it now.
Okay. Well,
Let me come back on and see here. I know you logged in as a panelist, so you should be able to do
yeah.
that. Do you want to email it to me and I'll pull it up?
Let's see if
Try again.
I share screen.
Welcome to live television, everybody. Oh, there you go. You got it.
Is it working?
Yeah, you just need to change the slideshow to play from start.
Yes, yes. Sorry,
Awesome.
give me
Thank
one
you.
moment here. Right, you know.
And then you put your video on so we can see you while you're talking. Thank you.
That's what I was having trouble with. I think my video, that part, it wasn't letting me do, but you can all hear me at least.
Yes, we hear you fine. Thank you.
Okay.
Great.
And I'm trying to get rid of this.
Oh, I think I can do that on
Okay.
on that.
Okay.
That's me. Ask to start
Hmm.
video. There you go.
Ah, okay. Sorry, and things were well. Hi. got that done. Well, thank you, everyone. Thank you for that lovely introduction. And I am honored to be here today to help talk about genetic counseling and testing for aortopathy. I appreciate the invite, and I certainly hope that it will be helpful to those that are listening. And I have no disclosures. And yes, that's where I am physically now, over there in Portland, Oregon, Pacific Northwest, and it's raining. So this is just a brief outline of what I'm going to review. I think you'll hear some reiterated points that that Laura also shared so excellently. But I'll also sort of get into some more specifics for patients and families about who should get genetic testing, the types of results, and just sort of maybe some things that are overlapping or maybe unique to the process of getting genetic testing for people that are in the United States. So this is something that Laura very well reviewed already, that what is genetic testing, that it is a laboratory-based test that examines some type of genetic material, whether it be chromosomes, genes, or specifically DNA or sequencing. And again, as Laura had said, that what we're looking for when we do genetic testing, and particularly for related to rare conditions, is a variation in essentially the spelling of a gene or the gene's particular instructions, because sometimes the difference in spelling can indeed then ultimately affect how does that gene function, which may be a little bit different than its typical function, and then can lead to certain symptoms or perhaps risks for certain conditions or health complications. As Laura had said, there are various sample types that can be used for genetic testing. And these days, it's very nice, I think, especially working in a pediatric clinic, where sometimes we recommend genetic testing, but you can tell a child they don't need to have a blood draw. We can just do a non-painful cheek swab. And sometimes that's the main question that most kids want to know when I meet them in clinic. Am I getting poked? So there are, again, Laura had reviewed some of this, certain types of genetic testing. The one that we're focusing on particularly today is what I would refer to as clinical or medical genetic testing, which is what is utilized for genetic testing for aortopathies. So this is a laboratory medical test that, at least in the USA, has to be ordered by a medical provider, that it is sent to a lab that has special certification called CLIA certification in the US. And that does have a cost that may or may not be covered by health insurance. And we'll talk a little more about that later. And this is very different than what is often referred to as direct-to-consumer genetic testing. So like where you can order your own kit and it comes to your home and you can find out some things about your ancestry or sort of perhaps wellness and health type of things. But these tests are not designed to be testing for hereditary aortopathies. And so that is not recommended for a way to find out about a genetic risk for aortopathy. And then, of course, as Laura had mentioned, research testing, which usually there is no cost for, but a little open-ended about do you ever get results and what may be learned from that. And Laura already reviewed about gene panels versus single gene. And then the other one I would add in that I'll talk more about in a little bit as well is something that most of the labs refer to as, quote, family variant testing. So if there is a specific single letter change or spelling change in a specific gene that has already been identified in an clinically affected member in the family, excuse me, then family members, instead of even needing a whole single gene analysis, may just be tested for one specific single letter change. And again, I think Laura reviewed this quite well, but I think it always bears repeating. Why would someone think about doing genetic testing if they have an aortopathy personally or in their family? And really the key is prevention and proactive care. So sort of thinking about this as knowledge is power, and that as genetic testing is one of the various tools that are used in the healthcare and management of people that have aortopathy or themselves or in their families. And the idea is that as Laura said, based on a certain gene, it may guide how often you get monitored, which blood vessels you get monitored for, in addition to the aorta, other things you might look out for if you have a syndromic form. And as she alluded to, also that sometimes based on a particular gene may tell the surgeons that if they see your aorta getting to a certain size, that it's time to do aortic surgery, which is really in a preventative way to attempt to reduce the risk or prevent a dissection. Because as I'm sure many of you know, perhaps even better than I, that a dissection is an emergency situation. And so genetic testing, similar to imaging and monitoring if someone's aorta is growing, again, is a tool to provide information and again, for people that have aortic enlargement, as well as for relatives to know whether they indeed have the risk or not. Because as Laura mentioned, that for most conditions that we're talking about, there is a 50-50 chance for children of someone with hereditary aortopathy that they don't have the genetic risk factor, and then they don't need any imaging at all. So who specifically do we think about recommending genetic testing for? So anyone that's had a thoracic aortic aneurysm or dissection at a young age, anybody that has one or more relatives that have had this condition, as well as people who maybe don't have any evidence of any aortic enlargement, but maybe you have other symptoms of some of perhaps the syndromic forms, such as lens dislocation in your eyes. That is something that it can be quite unique, for instance, to Marfan syndrome, or other kind of musculoskeletal features, as in some of the pictures that Laura showed. The other kind of key thing about genetic testing is who in a family do you test first? And in ideal situations, you do want to initiate this medical genetic testing in a person who has evidence of aortopathy, who's been diagnosed with an aortic aneurysm or dissection, versus someone who has either had an echocardiogram already, doesn't have any obvious signs, but has a close family member with the condition. And this, as far as it really being kind of key to decision-making about who do you test first in a family, has to do with current limitations of genetic testing. And this slide hopefully gives you more of a flavor of that. And so Laura had talked about the different types of variants that you can find in genes in our DNA. And so it is true that when someone has genetic testing for aortopathy, there are essentially three types of results that you may or may not get. One is a negative result, which means that the genes that were looked at, or gene, or specific spelling variant in one gene, was not found. And so, especially if this is the first person in the family to be tested, and it's negative, that doesn't mean that it's not genetic, but that the genes that were looked at, there was nothing found in their spelling that provides explanation or cause for that person's aortopathy. And so if you can't find a genetic cause in a person with aortopathy, then testing their family members is not going to be helpful either. And so again, but important that even if your genetic testing is negative, that still means it can be genetic. So your close relatives should indeed then use aortic imaging for monitoring for any risk assessment. The other thing is that our genetic testing is changing all the time, and there may be genes that aren't on a panel you have today, but in 2 or 5 years or 10 years, that there may be new genes to look at. And so it's appropriate to revisit that even if you have a negative test result. A positive means, okay, we found sort of the answer. Why do you have aortopathy and this is in your family, or at least that there's risk for family members. If you do have a positive result of pathogenic or likely pathogenic variant in one of these genes, it certainly can help, again, with management. And it does now allow the option of your family members to be tested for that specific spelling change. And for that kind of family testing, it's really a yes or no. Either you have that variant that was found in your affected family member or you don't. If you do test positive for a family variant, then we want you to continue monitoring for any symptoms or complications of the condition. If you test negative for a family variant, then you should not be at risk, nor should your children. So these gene variants don't skip generations. What you can, however, see is variation in what each person in a family who has a genetic risk factor may experience. So there may be someone that's experienced a dissection in the family. That doesn't necessarily mean that another family member who tests positive for the gene variant is going to absolutely have a dissection. And especially if you're knowing in advance that you're at risk and you take the proaction of continuing to be monitored to sort of head that off before it might become an emergency. One limitation of a positive result, however, is that it can't predict exactly what might happen to me in the future with a positive test. And again, there can be variation between family members. So it's not a crystal ball in that sense. And then, of course, we have what can be quite frustrating results are inconclusive or variants of uncertain significance. As Laura referred to, we have 3 billion letters of DNA, and I think it's estimated that each person has several million variants in their DNA, and a lot of those may just be why we're unique and traits. So not every spelling change in a gene, even in an aortopathy gene, is the cause or is an increased risk for aortopathy. So sort of along the lines of a negative test, if you get only a VUS on your test results, that there still may be some underlying genetic cause that we don't know about. So retesting is important, and your relative should still undergo aortic imaging and monitoring, but we don't typically recommend that family members get tested for a VUS because whether you have it or not is not really giving us additional info as to your risk. So one of the things I know it sounds like that there are a lot of questions about is, okay, so you're telling me this is important. Well, how do I make this happen for me and my family, particularly in the US? And this tends to be the process that happens in the US that someone is referred to a genetic specialist, which often can take a while to get into. And then you're seen by a specialist. Sometimes there needs to be a submission to insurance to get coverage for genetic testing, and particularly before someone sends in a sample. And then results from actual testing once started are typically about 3 to 4 weeks. Now, I know that it can be frustrating for people to have to wait to see a specialist. And if it's a simple test, why do I need to wait for that? And one of the key things is that that a lot of providers, primary care providers or other specialists, minus the ones that are involved with GenTAC and people like Laura who are so very knowledgeable, that they don't get a lot of training in medical school in the US about genetics. And so particularly primary care have very little experience in knowing what tests to order, how to interpret results, and those things. So sort of in the same way that you want a cardiothoracic surgeon that has experience in aortopathy surgery, you do ideally want someone to be ordering your testing and talking to you about testing before the test as well as after, that has some experience in this specialty field. I want to say a little bit more, if I have a couple minutes, just about a couple other things about testing in the US. I will say that that things are improving as far as lower cost, as far as insurance companies covering genetic testing, starting to realize that this is an integral part of someone's medical care, especially for aortopathy. And that is something, again, that genetic specialists have a lot of experience in submitting for and even getting denials overturned sometimes. I will also say that some of the labs these days also even offer options for much lower pay if someone is getting pushback from their insurance or needs to self-pay. The other thing is that in the US, there fortunately are some laws that protect people. There's always concern about, am I going to get dropped from my health insurance because I have a positive genetic test? And there are laws that protect most health insurance from that not happening. This is the law that was enacted in 2008. It also that your employer can't demand to see genetic test results on you before hiring you. There are some limitations. This federal law, for instance, doesn't necessarily protect you getting denied for life insurance or long-term disability insurance. So these are the things that in a genetic session, you know, these things would be explored and discussed, so you feel informed about before you proceed with genetic testing. And again, even though it's still small specialty, access, I think, is improving between telemedicine and even sometimes what's referred to as concierge genetic testing. And so this is just at least one of the places that someone may be able to find a genetic counselor and figure out how they might be seen and pursue genetic testing for themselves or their family.
Great, thank you. Thank you for that great presentation, Jessica. We have a few questions, so if I can ask you to stop sharing, and then we're going to bring Laura back. You can see her as well. So, Laura, are you there? You can put your video.
Yes, I'm here. I am just having problems with thing.
Let's see. Okay, but I think you need to shut your screen. Shut that off.
Can you see my screen now?
I see your screen. You can stop sharing now.
Ah, okay.
And so we'll go to the questions and answer box.
Okay.
There we go. Yeah, we've got everybody. So the first question: what advice do you have for people with an aneurysm at a young age without other risk factors, but genetic testing doesn't reveal any known cause? Laura, let's start with you on that.
Yeah, so I think, well, Jessica actually answered that question a little bit in the sense that, well, first of all, there are two aspects. One aspect, of course, is the cardiovascular aspect. I mean, patients with aortic aneurysms, irrespective of the fact that they have an underlying genetic condition or not, they need to have regular follow-up by their cardiologist. And some of them will need also treatment even when there is no known gene involved. That's one aspect. And the second aspect is the genetic aspect, which Jessica very nicely explained, in which the fact that we do not find a gene at this point doesn't mean that there is no gene involved. And the research allows to include new genes every few years. So usually what we recommend is that when we have a high suspicion of an underlying genetic condition, that a patient would return 5 years later so that we can review and we can see whether there is a need of doing a new genetic testing.
Jessica, anything to add to that? I see you nodding along in agreement.
Oh, yes. And I think the only other thing I would add is even that it still means then that your close relatives, so your children, your siblings, or your parents, should then use aortic imaging as a way to monitor themselves, since you don't have a genetic test to utilize in that situation.
Jessica, let's start with you on this one. After a single geneticist determines that your VUS is pathogenic, what is the process that he or she might go through to get it officially changed everywhere in records and all that?
Yeah, so, and for lack of time, I didn't get to go into, you know, who decides what
Yeah.
a variant is classified as.
Mhm.
There are some standards through the American College of Medical Genetics as far as how much evidence do you need from various aspects, databases or research or other things, to call a variant benign versus pathogenic versus VUS. And so those guidelines were designed at least to try to keep labs consistent in how they were reporting, because there are many different labs that do this testing. But, you know, what a lab may classify a VUS as, and then what your doctor who knows you and knows your family may though give you an additional interpretation. So it is, I know that there are circumstances where a doctor says, well, I do think this is really the answer. And the labs won't necessarily, just based on that, change the report. So I can understand how that causes confusion, but the labs are also a little bit limited because they're following these guidelines. So, I mean, your provider's impression is important as well, especially if they have a lot of experience, but it could be that you don't formally get that lab to change the classification on paper.
Any difference in Europe, Laura?
Well, I think the main difference that I can say between the States and Europe is that I think in Europe, genetic testing is much more, goes much more together with the clinical practice. So for example, we see our patients here at the university center and we test the patients in our own lab, which means that we have meetings with the lab and that we decide together whether a variant is classified as a pathogenic or a benign variant. And that makes the mix between the clinical aspect and the molecular aspect is much stronger in the way that it interacts, and therefore whenever that we, for example, submit variants to ClinVar, usually is because we have had discussion with the lab and we have had segregation in the families, etc. And of course, if we think that a variant needs to be changed, then it's much easier to tell it back to the lab, and they will probably change the variant in ClinVar. But that's, I think it's just it's a different way of working simply.
Next question: if you have an intron mutation, can you get embryos tested for the mutation so that you can identify affected embryos during IVF? Jessica, you want to start with that? I don't know what intron mutations are, so maybe start there.
Right. So I think what that refers to, as Laura was explaining, the exons are sort of the coding portions of genes, and introns sometimes are sometimes the sequence of DNA either in between exons or outside of genes. Sometimes I think of introns, sometimes perhaps as sort of manager kind of things. I admittedly can't say absolutely. Could an intronic sequence variant be tested prenatally or embryos? But generally speaking, I think it's possible, because just these days, as far as IVF or prenatal testing or embryonic testing, that DNA sequencing can generally be done.
Laura, you want to add to that?
It's a complex question. I have to say, just like Jessica, I have no experience in testing introns in embryos. So I cannot say for certain if that's possible or not. Certainly, if you have a mutation in so it's a difference between the first part of the intron and when there is a mutation deep in the intron. That it's certainly different. When there is a mutation in the first part, I'm talking about the first 20 to 50 base pair, then that's not going to be a problem. When there is a mutation much deeper in the intron, I think it can be problematic, but I will not there. I don't have the experience with that, so I would not dare to say a black or white yes or no.
So somebody is saying that they were told at a Marfan clinic that they have a connective tissue condition, but the genetics department at a particular hospital, and sometimes it's not the genetics department, sometimes I've heard this in other places, it's just a pediatrician or cardiologist, doesn't think the person needs genetic testing. So what kind of advice can you give that person who really wants to know, you know, as definitively as genetic testing can tell you, you know, what they might have for reasons you guys talked about for treatment and management decisions? Who wants to go first? I don't want to pick the wrong person. All right, Laura, go ahead. You go first.
Yeah, sorry, I was struggling with my micro. I couldn't find it anymore.
Okay.
So if I understand it correctly, so parents of people think that they might have a genetic condition, but the referring doctor will thinks that it's not necessary to do genetic testing. And the question is, how can they deal with this?
Yeah, and not only sometimes it's parents, but sometimes like this particular person is saying that they were actually told they have a connective tissue disorder.
Okay.
But the genetics department doesn't was dismissive about getting a test. So
Yeah.
sort of the same problem.
Yeah, I think that's a difficult question. I think that my experience, there are two things of that to that question. One is that I see sometimes people who have been told that they have a connective tissue disorder, and when I look at them and I take all the data together, I don't think that they have a genetic disorder, and I try to explain why I think that's the case, and I try to explain to them that indeed having a genetic testing is not useful, because it will not give us answers, and it might just provide more questions. So it can be that the advice of not getting a genetic testing is a correct one. Of course, it will depend on the situation of the person itself. And maybe I just want to add that maybe having that advice is a positive thing as well, because it means that you might not have a connective tissue disorder indeed. Of course, the different thing is that when the advice is not correct, and here in Europe, for example, a possibility is that you are referred to a different center to have a second opinion and get genetic testing in a different center. I assume that in the States is a similar thing, but maybe Jessica can comment on that.
Yes, it is true. I would say there are certainly people that we see in our Marfan and related disorders clinic where genetic testing is not recommended, and probably quite a few patients who are referred with hypermobile joints, but nothing else in the family or in them, and they've had a normal echo. And it's true, we don't and really don't have the capacity to see every patient that has hypermobile joints. There are other things that we kind of look as maybe concerns if there's aneurysm in the family or other things that speak to a syndrome that has a genetic test that can confirm that. Those are the type of patients that we see. And I know that there's another form, there's many different forms of Ehlers-Danlos syndrome besides vascular, and one of the most common forms that is referred to as the hypermobile type, we don't have a genetic test for. And so sometimes when it's that type that's most suspected, there isn't genetic testing to be offered for that.
Okay, I see a question here that comes up a lot. What are your thoughts about people in the same family having different aortopathies? I know, you know, maybe one person has Marfan and another has loeys-dietz. I just want to throw out there that this question was asked to Hal Dietz a couple weeks ago, and he said, I think you guys will agree with this, that he's learned everything in genetics is possible. Anything is possible, but the question is it probable? So, Laura, do you want to start with that?
Yeah, I fully agree with that comment. So normally when there is a orthopathy in a family, you would expect that it would be the same gene involved. The question, of course, if the members of the family, if not all of them, have had genetic testing, well, maybe it is possible that a clinical diagnosis has been made of Marfan syndrome, while the underlying gene is, for example, a SMAD3. We have those patients in which they clinically have the diagnosis of Marfan syndrome, but when we look at the genetic testing, it's a SMAD3 patient, which is one of the genes causing loeys-dietz syndrome. So that is one possible explanation on why that there are families in which they hear from the doctors, you have Marfan syndrome and you have loeys-dietz syndrome. Well, probably they all have exactly the same, but because one has a genetic diagnosis and the other one has a clinical diagnosis, then it gets a little bit intermingled. That's one thing. Another thing is that, I mean, in genetics, indeed, everything is possible. And we have also had families in which there are indeed 2 mutations, and that's just chance, and that's a very bad luck, but that can also happen. And of course, we also have sometimes patients with family members who have a mutation and have an orthopathy, and there are other family members who have an orthopathy without a mutation. And sometimes in those family members with an orthopathy, the reason of the orthopathy is maybe hypertension, or is an infection, for example, in the past, or other reasons why you can have an orthopathy besides a genetic cause.
Okay. One last question, Jessica. Is it possible to determine whether a child is affected before it is born? Like, I guess, genetic testing,
Yes. So generally speaking, yes, if certainly through genetic testing, if there's a known pathogenic variant in the family, these days with genetic technology, that theoretically can be tested for in an embryo, during a pregnancy, or after birth.
Great, thank you. There are a few more questions, but I think we need to kind of close it up. It's been an hour. So I'm just going to share my screen again. And right here is our Help and Resource Center. Jan Lynch is the director. And if you can take those questions that did not get answered today and go to marfan.org/ask. That's truly the fastest way to get answers from Jan. You guys had such good questions, and the presenters were amazing. So thank you both so much for being here with us today, and thank you everybody for joining and for those questions. A couple other things I wanted to share with you all before we go back to our speakers and to Michael. Our next webinar is on eye research on May 2nd. You'll hear from Dr. Jefferson Doyle from Johns Hopkins and Dr. Deborah Vanderveen from Boston Children's Hospital. Not sure if that's going to be recorded, so definitely register and plan to do it live if you can. It'll be at 7 o'clock at night. It just depends what they're presenting. I need to check with them on that. We are in person in several locations in the next few weeks. This weekend, we have New York City Regional Symposium on April 15th. Incredible agenda there. We'll be in Denver on April 29th, and we'll be in Ann Arbor, Michigan on May 6th for our famous regional symposium, which, these are not only hearing from great experts, but getting a chance to meet people in person. And as awesome as these webinars are, we have the whole other element of meeting people in person if it's near you. So those are coming up. Go to our website to register for those. We have Family Camp coming up first weekend in May for anybody who would like to bring their family. Register now. Time is drawing near for that deadline. And also another chance to get together. We have walks coming up throughout the US, but I want to point out for this group that we have our global walk on Saturday, May 13th. So that's online. We have our famous DJ and we have fun and games. And so I know there's a lot of competition between the countries now, but it's not really about competition. It's really about creating community. In some places, people are getting together to do something and then also going online, or you can do it from your home and you can be part of our global community from there. So that's Saturday, May 13th. If you go to marfan.org/walk, you can check out all these upcoming walks as well as the global walk. And then, as Michael mentioned earlier, our in-person conference is in Chicago this summer, April 13th to 16th. This Friday is the deadline for scholarships, which cover registration and hotel. and for health fair appointments. So if you're interested in those, a lot of you have questions, or you're not sure exactly about your diagnosis, that would be a great place to go to find out more about that. Before we close it all up, I just wanted to go back to Michael. Any final thoughts from you? This great presentations today.
Just thank you very much, Laura, Jessica. That was terrific. Great attendance. Good to see so many different parts of the country and the world represented. And hopefully we'll see everyone in Chicago. If not before, you know, you can spend almost every weekend right now with Marfan, if you're so inclined.
Jessica, any final words?
Oh, no, just thank you again for including me, and again, hope it was helpful for people.
Yeah, I see a lot of clapping hands coming up on my screen, so people are loving this. Laura, finally got a chance to present in English today. Usually I call on you for Spanish, but any final words?
No, I just want to join Jessica in thanking you for organizing this this webinar for the GenTAC, the Marfan Foundation. I think you're doing a great job, and I'm really glad to be able to be part of it.
Great, thank you so much. I see a question about the recording, so we will get this recording up on our YouTube channel. Everybody who registers, I'll send you all the link if you want to share it with any family members, and it'll also be up on our social media, the link to it. So thank you, everybody, for taking time out of your day to be with us today, and look forward to seeing you again.
Eileen, thank you for hosting.
Sure, anytime. Take care,
Bye.
everybody.
Thank you.